A 55-year-old male presents with dull retrosternal chest pain and a persistent dry cough. I am showing you an axial contrast enhanced chest computed tomography scan. Describe the findings.
The axial contrast enhanced computed tomography scan demonstrates a lobulated, soft tissue attenuation mass in the anterior mediastinum. The mass has poorly marginated borders and appears to abut the ascending aorta and pulmonary trunk, with loss of the intervening fat planes, suggesting local invasion.
State your primary diagnosis and identify the mediastinal compartment involved.
The primary diagnosis is an aggressive anterior mediastinal neoplasm, most likely thymic carcinoma or invasive thymoma. The mass is located within the anterior mediastinal compartment, anterior to the heart and great vessels.
What is the general differential diagnosis for an adult patient presenting with an anterior mediastinal mass?
The primary differentials are the classic 4TS, thymoma or other thymic neoplasms, thyroid mass like a retrosternal goiter, teratoma or germ cell tumor, and terrible lymphoma.
How can you differentiate lymphoma and teratoma from thymic neoplasms on computed tomography imaging?
Lymphoma typically presents as a lobulated, multinodular mass and is usually associated with lymphadenopathy in other thoracic compartments. Teratomas characteristically display internal heterogeneous tissue components, particularly macroscopic fat attenuation and coarse calcifications.
Which thymic epithelial neoplasms are most common, and how do their margins typically appear on computed tomography?
Thymic epithelial neoplasms, particularly thymomas, are the most common primary anterior mediastinal masses in adults. Benign or encapsulated thymomas typically demonstrate well-defined, smooth margins. Conversely, invasive thymomas and thymic carcinomas exhibit poorly defined, irregular, and infiltrative margins.
Compare the dissemination and metastatic patterns of invasive thymoma versus thymic carcinoma.
Invasive thymoma characteristically spreads locally, invading adjacent mediastinal organs, the pericardium or pleura, often leading to pleural drop metastases. In contrast, thymic carcinoma is highly aggressive and metastasizes hematogenously to distant organs such as the liver, bones, and lungs.
What is the clinical significance of a thymic carcinoid, and what syndrome is it associated with?
Thymic carcinoids are neuroendocrine tumors that are highly aggressive and often secrete adrenocorticotropic hormone, causing Cushing's syndrome. They are strongly associated with multiple endocrine neoplasia type 1, or MEN1, syndrome.
What clinical preoperative screening is mandatory in patients suspected of having a thymic mass, and why?
Mandatory preoperative screening for myasthenia gravis is required by testing acetylcholine receptor antibody titers. This is critical because approximately 30 to 40% of thymoma patients have myasthenia gravis, and they are at high risk of a perioperative myasthenic crisis under anesthesia.
Under what circumstances should a biopsy of a suspected thymoma be avoided?
A biopsy should be avoided if the anterior mediastinal mass is encapsulated and completely resectable on computed tomography. Performing a percutaneous biopsy in these cases carries a significant risk of pleural tumor tract seeding, so patients should proceed directly to surgical thymectomy.
State the critical safety warnings associated with this anterior mediastinal mass and your management recommendations.
The critical safety warnings are airway or superior vena cava compression leading to acute obstruction, myasthenic crisis, and pleural seeding from biopsy. Radiologists must immediately recommend thoracic surgery consultation for resectability assessment, advise checking acetylcholine receptor antibodies, recommend complete surgical resection, and suggest staging computed tomography. Refer to thoracic oncology and cardiothoracic surgery.